are going to continue on with the rotator cuff. So we went into the life of the brachial plexus. So what we're going to do today, hopefully, is complete the rotator cuff and then talk about all the different places of entrapment of the brachial plexus. We'll do a little activity tomorrow. Tomorrow, I will warn you, I'm going to be a little bit late. I will probably get here. I have a 5K meeting, and it's the only time that the rest of the people can meet on main campus. So I will post your assignments for you tonight, and I will get here probably at 10:35 or 10:40 at the latest. So just start without me, okay? So just a review of rotator cuff. So the anterior rotator cuff, we're going to be looking at subscapularis, and you can see a little tiny bit of supraspinatus there poking through. And then from the back, parts of the rotator cuff, we have supraspinatus, infraspinatus, and teres minor. Okay, so you can see the blending of the tendons on the superior, middle, and inferior facet of the greater tubercle, and we have cut off teres major at the bottom because that is not part of the rotator cuff. All right. So when some people talk about the rotator cuff, they use the mnemonic SITS, S-I-T-S. Okay. So I'd like to show this slide because it looks at the biomechanical problem that we have that is created by the deltoid and just by the shape of the head of the humerus. Okay? So we have this very large muscle that I spent some time talking about with you on Monday with its angle of pennation, and I told you it's very powerful and can produce a lot of force because of that with its contractions. So the deltoid inserts into the deltoid tuberosity, excuse me, which is about midway down the humerus. So when the deltoid fires, it essentially wants to pull your humerus up, okay, just because of the way that it inserts. So it would ram it into the acromion process, all right? So we have to come up with some sort of anatomical band-aid or fix to prevent that from happening, okay? So what we have is the rotator cuff. So because of the way the rotator cuff inserts on the superior, middle, and inferior facet of the greater tubercle, and then the subscapularis on the lesser tubercle, if you look at these arrows and the line of pull, what that does is it creates an inferior translation of that humeral head, okay? So one of the things that it does is it helps clear the humeral head from the acromion process when you bring your arm over your head, okay? Because remember, deltoid's not really going to fire when I'm just standing here. Deltoid's going to fire, anterior delt will fire if I go into flexion, middle delt will fire if I go into abduction, and then posterior delt into extension. The other thing the rotator cuff does is it allows for stability in there, right? So we keep talking about there's this large head of the humerus, relatively speaking, compared to the flattened glenoid. So when we have a joint that has so much mobility to it, the head of that humerus wants to move around, so we need to have things holding it in place. So we have the capsule, we have the labrum, and then we have the rotator cuff. So this allows for dynamic stability. So you'll talk about things, I don't know if Julie's really touched on it, you'll talk about structures in orthopedics that allow for static stability. All right, so I have static stability, if you think about posteriorly of my shoulder. I don't really have people subluxing their shoulder posteriorly because I have static stability when I'm just at rest. I have my scapula there. I have my rib cage. I have my lats. I have my traps. So it's just not going to go posteriorly because I have things blocking it. Okay. Anteriorly, I don't have a lot. I have the capsule, right? That's, you know, the labrum is more sort of circumferential, but from prevention of anterior, it's pretty much capsule and skin. So rotator cuff is dynamic stability. So when I am moving, that rotator cuff will contract and help me keep the head of that humerus down and also in the side. Okay? So when people have a compromised rotator cuff, that's when you start having problems. one of the first problems that you have is you have superior translation of that humerus, and it starts hitting the acromion. Okay? Now, once you get into orthopedics, sometimes what happens is you have a weak rotator cuff. It's not that it's compromised, it's just that you don't use it a lot. All right? So, because the two major actions of the rotator cuff really are internal and external rotation, right? So we talked about supraspinatus starts abduction, but we achieve that. We talked about that. So we have teres minor, infraspinatus, external rotators, subscapularis, mostly internal rotator, okay, with teres major. So their prime actions are rotators. So we don't do this a lot throughout the day, okay? So the rotator cuff usually is not that strong. So then what's happening? We don't really have a lot of dynamic stability, especially if we also have bad posture on top of that. Now our scapula is abducted, okay, or protracted, anteriorly tipped, and probably upwardly rotated. Okay, so now to try to clear my humerus, I have my acromion in a bad place, right? And then I don't have my rotator cuff kind of helping me depress that humerus. So then what happens is then I start actually compromising my rotator cuff even more, because now my rotator cuff gets pushed up against the acromion process and can get frayed. Right, so if my palm of my hand is an acromion process and here's the head of the humerus, rotator cuff runs in between. Okay, so then it can get torn. And you can have minor tears all the way up to major tears and a complete full thickness tear. All right, so this is looking at the rotator cuff from above. Okay, so here we have our large acromion process. All right, the only thing I did not plan for was to bring a stylus. All right, we have it abutting with our clavicle. All right, then I have a ligament here. This is going from the coracoid process over to the acromion. Coracoacromial ligament. Okay, it forms an arch. And then look, I have my supraspinatus tendon. Right? Which one did I say was the one that was most injured, most frequently injured? Right. So if you're looking from the top down, that supraspinatus can pretty easily get pitched under my acromion, okay, under the acromion and clavicle junction. And then if I have any kind of compromise in this ligament, it can get trapped under there as well. Okay? So you can see kind of from this view, I have my subscapularis is here. Okay, so can get compromised as well, not as often. And then here in the back is my infraspinatus. Okay, but just like to show this view to kind of give you an idea of why the supraspinatus is most commonly injured. All right. Just looking at another view, all right, you can color this in on your own. Just actually, here's a little note to us. Teres major has been taken out, just to remind you of what the rotator cuff is comprised of. So we have supraspinatus, infraspinatus, teres minor, subscapularis. So a little repetitive, but I think the rotator cuff is exceedingly important. All right, so then reminding you, because I know that we have been doing some gait here and there, reminding you of the other muscles that are covering over that rotator cuff. So when we were looking at the back, we had traps. Okay, so we were spending a lot of time talking about upper trap dominance and how that then pulls on the spine of the scapula and can get you to go into elevation, which is not necessarily a great position for your scapula to be in at rest. Okay, and then we also have levator scap is also contributing to that as well. So a lot of people who are upper trap dominant are also levator scap dominant. It's just because you're sitting with these rounded shoulders and forward head. So that attaches to the superior angle of the scapula, also pulling that up. These muscles also often hold a lot of trigger points in them because they are overused. All right. One of the ways to try to not overuse those is to fire the rotator cuff. All right. So lots of the rehab that is associated with this, okay, is trying to trigger scapular stabilizers, so trying to trigger rhomboids, okay, also serratus anterior, so you can keep your scapula back, but then also to have a healthy rotator cuff, so that you're compressing and pulling and getting that inferior translational force on the head of that humerus, okay, so it doesn't bang into that acromion process, all right? So these are all the things that you guys should have seen in lab, because we're going to be in supine for a while, so just wanted to remind you of what we have in the back. All right, here is a representation that people like to use. I do this all the time with patients in the clinic, just so you can see where subscapularis touches at the lesser tubercle, supraspinatus, infraspinatus, teres minor, all on this set of greater tubercle. Now, not to be dismissed is the intertubercular sulcus. You've also heard it as the intertubercular groove. Long head of the biceps runs right there. Okay. I didn't get out of control. I usually get a little bit out of control. I wanted my line to go all the way up here. Okay. We are going to talk a little bit about how biceps, long head, contributes as the fifth member of the rotator cuff. All right. It's really not a rotator cuff muscle, but the biceps attaches to the labrum. Okay. The rotator cuff attaches to the labrum. So your biceps can help you with stability of the shoulder, as well as if you fire your biceps too aggressively, it can tear the labrum and then lead to major shoulder problems. Okay? Triceps also attaches to the labrum, but we won't talk about that until next week. All right, so now that we're talking about the labrum, if we look at medial view of the scapula, right, all I want to look at here is how flat the glenoid actually is, right? And then we have that very spherical head of the humerus that has to fit in here, okay? The glenoid is not only flat, it is small. Right, so if you compare, I would say the head of the glenoid is about the size of a quarter, and the head of the humerus is at least the size of 50 cent piece or larger. Okay, so we have that incongruity there. So we have incongruity of shape and we have incongruity of size. And think back to your femur in that acetabulum. That acetabulum fits the size of the head of that femur well. That's why it's very difficult for you to dislocate your head. It's deep, and it's the right size to fit inside of, to have that head of that femur fit inside of that acetabular notch. Okay? Here we have two issues. So, okay, we keep talking about the rotator cuff. So I've cut all the muscle up. The rotator cuff's going to come around and attach on my humerus, which would be right here. Right? So that's going to hold it in next to the glenoid and allow for a little bit of stability. And then because of that dynamic stability, it will have the ability to move that humerus. All right. If it's not working well, we don't have dynamic stability, it's not going to help, and the humerus is going to creep up. If it is contracting and working well, it's going to pull that humerus down. Okay. So let's go one step further. Let's look at what is actually attached to the glenoid. Right. So in the prior slide, I had taken everything off the glenoid. Okay. So same view. So here's our glenoid right here. So you can see what we have is at the top, we have supraspinatus, infraspinatus, teres minor. So we have those tendons coming around of the rotator cuff that are going to allow and give us some stability to this biomechanical problem that we have. Okay. Then what we have is here, this BT, that's your biceps tendon. All right. So if I were to identify the labrum on here, if I made my labrum yellow, I have the long head of my biceps tendon coming up and over and attaching to the top of my glenoid. Okay? I remember when I was in PT school, I'm sure I learned this. But with all the other things that I learned, I was like, oh yeah, biceps attaches up here. And until I worked at a shoulder clinic, because I also was like truth telling, and I was scared to death to work on shoulders when I came out of PT school. So it's like, they're so complicated, shoulders and feet. Now I'm like, those are my two favorite things. But it made perfect sense to me the very first time I saw someone that had a slap lesion. So a slap lesion is a labral tear. You can have all different kinds of labral tears, but a slap, S-L-A-P, is a type of a labral tear. Okay, so what it stands for is superior labral, anterior posterior. So the labral gets torn superiorly, and it goes like this, peels down. So you have a cut in superior, anterior, posterior. Most people that have a slap lesion are people that have a massive force coming through their biceps, and it peels back the top of the labrum. Okay? Now, not everybody's going to work in the type of clinic that I work in, but one of the most prolific sets of people that I see with this are pitchers and outfielders. Because the biceps, this is going to be a little foundations, when you're using an overhead throw, the biceps is slowing your arm down eccentrically. And that accrues a massive force. Because think about how fast pitchers pitch. Right? That's all biceps slowing them down. So really at risk for slap lesions. I've seen a lot of slap lesions too with like high force trauma, like skiers and snowboarders and things like that, when they just put their arm down and their body goes, tumbling forward. I also saw a really gnarly slap lesion. One of my good friends had to call the emergency room, and I was like, you can't call the emergency room for stupidity. She thought it was a really good idea to do kettlebell workout after she hadn't worked out for like 3 years and was doing a Jillian Michaels video in her basement. And she went like this, fell backwards, and completely dislocated her shoulder and got a slap lesion in the process and a Hill-Sachs fracture. And I called the emergency room, was like, I'm lying on the floor of my basement! I have a kettlebell on me! And I broke my shoulder. I was like, way to go. Day one of the new workout regime. So, I told you, you can't fix stupidity sometimes. Okay, so that's your biceps tendon. Later we will learn triceps tendon inserts down here, inferior glenoid. What the book actually says is, for the biceps tendon, supraglenoid tubercle. Top of the glenoid, okay? Triceps, infraglenoid tubercle, bottom of the glenoid. All right, but it actually attaches to the labrum, so that's important. When somebody has a torn labrum, it's just like if they have a torn labrum in the hip, that compromises the integrity, right? So if you look at, this is really what's deepening my socket. So these are patients that come in, they have pain, it feels deep in the joint, and they feel clicking. And you're like, right? So any kind of clicking in there, I don't have even this guy in here, right? That's my labrum that I am feeling that kind of clicking or popping. Or if you feel the head of the humerus kind of roll over it, like it's like a little tear in there. So pretty indicative. So most of these are surgical. Why? Because you have majorly disrupted a key player in keeping the stability of your shoulder joint. Okay? Plus the biceps is a pretty important muscle that you would like to use in a lot of activities, even if you're not pitching. At any rate. So I had a great anatomical story happening in the training room yesterday. I had a kid come in who is an outfielder, and he was like, I have a lot of pain, because I see a lot of pitchers, and they all have elbow pain. So he comes in, and he's like, yeah, I have elbow pain, it's right here. He's like, totally thinks, like, I'm like, oh, I don't need Tommy John. And I'm like, you don't need Tommy John, because that's the wrong side of your elbow. So I'm like, he's like, it's right here, the pain is right here. I'm like, that's your biceps. And he looks at me like I just, I don't know, walked out of a, preschool class. And I'm like, Dad, 3 biceps extensions. And he's like, well, I'm really, I'm using my elbow a lot to like swing on the ball. And I was like, that's not your elbow. So then he goes, I also have this pain deep in my shoulder. I'm like, that is the other end of where your biceps attaches. And he's like, no way, my biceps is here. I'm like, it is. But it attaches here. It's this athenerosis, this wide portion that goes right in the middle of your elbow. I said, and then it has this part called the long head biceps that attaches inside of your shoulder. And he was like, oh. So it was pretty cool that I could like explain to this guy, you know, got my street cred. But I mean, it was perfect for me because he was exactly explaining, even though he thought I was an idiot, he was exactly explaining both attachment sites of the biceps. Like he was a perfect patient. He was just like in the middle of my elbow and right here. And I was like, great, I don't even have to touch you. I know what that is. All right. So what are all these things? SGHL, MGHL, IMG, Chelsea. They're all a capsule, right? So superior glenohumeral ligament, that comes into and blends with the capsule, all right? Medial glenohumeral ligament, inferior glenohumeral ligament complex, right? So these are the glenohumeral ligaments. These guys blend in with that capsule. So they're not part of the capsule, sorry, they blend in with the capsule. Sorry if I misspoke. So here is looking at some of the other, now these are, you know, what are considered capsule is considered static stability. The capsule can become wound up in close packed position, but the capsule is not contracting, right? So you don't have these questions when you get to orthopedics, what's static stability, what's dynamic stability. So like you could also say like the static stability of the hip is just the congruency of the femur fitting into the acetabulum. Like you don't have to do anything for that to happen. Anatomically, that's just the way it is. And anatomically, you have this capsule, so that offers you static stability. Dynamic stability is going to be your ability to fire your rotator cuff. Okay, so it's not that if people are weak and don't strengthen the rotator cuff, they're not completely unstable in their shoulder. They have a capsule, they have these ligaments. But they don't additionally have this dynamic stability. All right, so this brings up a point if you have a patient who has a lot of capsular laxity. So people just have that. And I was talking about swimmers, a lot of times have that and they want to keep it because that allows them to do a lot of range of motion, especially into extension when they're doing backstroke. They really need to have a strong rotator cuff because they don't have any static stability because their capsule is stretched. Okay, and their ligaments might also be stretched. So they need that rotator cuff to really, really help them with that dynamic stability. Okay? So here's a little picture just of, if we look at the blue, so this is the glenohumeral ligaments that we have over here. Okay, and you can see this inferior, there's two of them, that's why they call them a complex. So here the labrum is labeled in green, we have the ligaments in blue, and then we also have that long head of biceps coming down to the attaches to the labrum. That's going to also add a little bit to our stability. So do you think biceps is dynamic stability or static? Is it a muscle? Does it contract? Yeah, so it's dynamic. Okay. Most of the time what happens though is biceps doesn't really have an influence over pulling the head of the humerus up. But you can get yourself into trouble if you have too forceful dynamic contraction of biceps so they can pull and peel off of that glenoid. Okay, so this is just looking at a different view, and the reason why I show you this is because I love how you can see the long head of the biceps tendon right here, and how it is actually attached to the labrum. And that's why you get those labral tears. The other thing that's great about this is you can see bursa in this picture. Okay, so here we have this subacromial bursa. That guy gets smashed a lot, especially if you don't have a strong rotator cuff and you're painting overhead. If I don't do rotator cuff exercises, all that happens is the head of my humerus goes up, and it can either smash and fray the rotator cuff tendons, or it can squish that bursa. Treatment's pretty much the same for both of them, right? You know, bursitis is different than tendinitis. It's just tissue that is inflamed, but the treatment's going to be the same. I got to get the pressure off of what is ever getting compressed underneath that coracoacromial arch. Okay? And this is what I was talking about. There used to be a surgery they did called acromioplasty. They just clipped their acromia off. Like, well, that solved the problem. It's like, but it did not solve the problem of the head of the humerus creeping upwards. Okay, so it took people out of pain, but it didn't really help them biomechanically at all. All right. This picture I also like because it shows how those GH ligaments all sort of wind together and will combine with the capsule to offer you static stability. Okay, and then here, even though we're not getting to it yet, is my triceps, which is going to insert on my infraglenoid tubercle. So triceps is not as frequently an issue unless you've been tearing up the labrum. You can have issues with your shoulder with the long head of the triceps. You can pull on the capsule. Okay, but biceps is right on that labrum. All right, the other thing that you can see here is we talked about this in a couple of days ago. There's a lot less stuff. There's a lot less stuff down here. Right, if you look at all of the redundancy of the ligaments up here, and how they're kind of winding together. So that's why we do inferior subluxation. Right? If we sublux or dislocate the shoulder, it's usually anterior, inferior. Okay? And we also will try, if patients have like the opposite issue where they're really tight in here, we try to pull them a little bit inferiorly to try to get some movement inside of that capsule. Okay? So we can stretch them out. So the rotator cuff is complex, but it is very cool. Very cool. This is a great figure because it looks at all of the tendons coming around, as well as how they could get compromised underneath that coracoacromial arch. All right. So here's our supraspinatus tendon. So that guy really easily can get smashed in there. And then there'll be a bursa right in there. Here's my biceps tendon coming up underneath onto the top of that glenoid labrum. And then I have a transverse ligament of the humeral head that's going to hold that biceps tendon in place. You can feel that. You can actually have a patient, because I was telling you, even though we haven't done the actions of the biceps yet, it's an elbow flexor and it's a supinator. So you can actually feel, right, you can find the greater and lesser tubercle, and you can feel if you have somebody supinate and pronate, you can feel that tendon kind of moving back and forth in this ligament. This ligament is important. If that ligament was not attached, you would then have this angle coming in, this tendon would be freed, it wouldn't be tacked down, so that would put you at an increased risk for getting more of a labral tear. Okay. You have a lot of people that will go in for a shoulder scope, and they'll come out and they'll say, oh my gosh, I have a scar here. I didn't think I was going to. They told me I was going to have holes. And I'm like, that's because your biceps tendon was compromised and they went to fix it. And a lot of people, that's the most painful part of the surgery, is the repair of the biceps tendon, not the actual rotator cuff. But they're finding out more and more about how the biceps contributes to that dynamic stability of the shoulder. So you heard it here first, but it won't be the last. All right, here's just an overview of looking at, I show this to patients a lot, okay? So there are different types of acromion. This is a real orthopedic talk, so we won't really talk about the types of acromion here, but you can have an acromion that has a beak on it. So acromion shapes come in, I think, 1 through 4. So you'll read a lot in the orthopedic literature about there's certain people who, depending on the shape of their acromion process, they're going to be at an active increased risk of rotator cuff tears, kind of no matter what. Okay, but if you have arthritis, or if you have bursitis, and so the bursa is supposed to create a friction-free environment for those tendons to move. So if you have long-standing bursitis and that bursa is not doing what it's supposed to anymore, you can get roughening, or you can get arthritis forming on that acromion process, which then can, form these little osteophytes and come down and start fraying your rotator cuff tendons underneath. So occasionally, too, what you'll get as a surgery is they'll go in and they will just smooth your acromion instead of taking it off. So they'll clean it up, okay? And if you have some fraying, they'll repair. They don't have to do, it's not completely torn. They don't have to use like anchors and sutures, but they'll try to repair. They can use sutures, not anchors, sorry. They'll try to repair with some sutures that fray the tendon. But you can see that was painful, right? Okay. And it's a pretty intense pain when people have rotator cuff pain. And it doesn't necessarily go away when they put their arms down, right? So it's kind of like a dull ache all the time. It also hurts when they sleep, if they sleep on their side. So that's a real issue for people, especially if they've been sleeping like that for a long time. So then eventually what can also happen is you can get instability. So if you have this going on, and your rotator cuff tendons can't pull and depress the head of that humerus, then you get degeneration in the labrum. Your labrum is going to be trying to do a lot more stability, sadly, than it should. It doesn't have the help from the rotator cuff. Okay? So then you have people that can have labral issues that way. So I see labral tears in people who have long-standing injury, and then I see labral tears in people who have had a traumatic injury. All right, and this is just looking at what the labrum actually looks like in situ, and then in an MRI. So it should be nice and smooth, and it helps deepen that socket. All right. So rotator cuff, I forgot to tell you guys where you can find it. So in the armpit, okay, although we refer to it as the axilla, all right? So the axilla has boundaries to it. So what makes up that diamond-shaped area that we refer to as the armpit? I told you all, Hagen loves to call any sort of fold in your body a pit, so he calls this the elbow pit, he calls the knee the leg pit. I'm like, love it. So the base of the axilla is going to be the skin of the armpit and the fascia of the area. The apex, so the top of it, is going to be the first rib, the clavicle, and the superior part of the scapula. Okay, so it's a three-dimensional structure, the armpit, or the axilla. And then we have the rotator cuff. We have the brachial plexus coming down through it, right? So that's what we kept talking about. I can get those structures, the blood vessels and the nerves, compromised underneath the first rib, clavicle. We also talked about pec minor. Okay. The anterior wall is going to be my pec major, pec minor. Posterior wall is going to be subscapularis, right to the front, the anterior portion of that scapula. Teres major and lats. Medial wall, upper rib cage, intercostal, serratus anterior. Lateral wall is my humerus. Okay, so that just gives you a three-dimensional view of what is in the axilla. Other things that you would find in the axilla, tons of lymph nodes. So when we have people that are undergoing a lymph node biopsy, which is unfortunately quite frequent with the amount of breast cancer that they're finding, one of the first places they go for an axillary node biopsy and then potentially axillary node dissection. So we can see a lot of orthopedic issues secondary to that because of all the nerves and the vasculature that is found in the axilla. Okay. I also have my axillary artery and vein, so hopefully they know what they're doing and you don't get a major bleed, because that would be akin to your femoral artery. So we're going to talk about the same branching that we had in the leg. We'll talk about that in the arm a little bit later. And then we generally, in the axilla, we find the cords, right? So we have lateral, medial, posterior cord. Okay, so you guys will be able to rattle off to me what makes up the lateral cord, what makes up the medial cord, and what makes up the posterior cord. So then we could talk about, if you had cords that were compromised, what that would look like in terms of the arm and hand function. All right, so this is just looking at the axilla, so it's triangulation, right? So we have a rib here, so we have serratus anterior as our medial wall, and the rib cage, lateral wall is humerus. Posterior wall, we have lats, scapula, subscapularis, and then the anterior wall, we have pec major and pec minor, okay? And then we have all of this beauteous and loveliness inside of the axilla that we were looking for in the lab on Friday. All right, so if we talk about the blood supply a little bit, one of the reasons why we spend time doing this is, first of all, because it's anatomically important, and we want to know what the blood supply is to the shoulder and arm, but also because there are syndromes that are associated with compromise of these structures. Okay. So the axillary artery, we find most of it it runs between the first rib and pec minor, okay? What you will see is just like we had in the leg, like we get these name changes. So it's a continuation, okay, essentially off the subclavian, all right? But we get these name changes as we go to critically important structures. The name will change again as we get to the teres major, okay? So the axillary artery can get compromised in between the first rib and or underneath pec minor, and that would be thoracic outlet syndrome. All right, now we talked about there's a lot of different types of thoracic outlet syndrome. This is one, okay? One branch that comes off in that area that's pretty important is the superior thoracic artery. And tomorrow, as you could imagine, one of your little activities is going to be looking at the chart in the book and seeing, okay, generally speaking, what does the superior thoracic artery supply? Okay, because we're going to go through where they all are today. All right. Posterior to pec minor, I get two branches that come off. I get the thoracoacromial branch and the lateral thoracic artery. All right, when I get down to the inferior border of teres major, I get the circumflex that are coming around the humeral head. So these should actually, even though the names might be a little bit different, you can kind of just plug and play where we had femoral and put in humeral, right? There's a lot of sort of redundancy. And then what we have to have is we have to have an artery that supplies our subscapularis, so we have a subscapular artery. Okay, we get this little portion of the axillary artery that continues as a subscapular artery, and then what will happen is it gets teres major and it changes names into the brachial artery. But I have two branches come off, the circumflex scapular and the thoracodorsal. All right, so the picture that accompanies that is here. All right, so we're really looking at anterior shoulder here. Okay. So if my finger works and can stay skinny, all right, we're going to identify our subclavian. Which is going to be here. Okay, and even though this was not really in order, let me back up for you guys. So if we did, here's my right, here's my left, and I have those as my common carotids. Okay. And then I had that brachiocephalic trunk on my right side, which is going to be here. Okay, so we talked about that when we talked about what came off of the external carotid and supplied the face and the neck. So we have this branch that's kind of small that is called the thyrocervical trunk that is right here. Okay, and off that thyrocervical trunk, what we have is a cervicodorsal trunk. That's going to continue on this way. And then we have the inferior thyroid, which is just this little guy right here. Okay? All right, so my subclavian is going to pass underneath my clavicle, and at the border between my clavicle and my first rib, it's going to change names, okay, and it's going to become my axillary. Okay, so it's not that it was a different real branch that came off, it just is a continuation. All right, so that will go under my pec minor, and if I could sort of envision my teres major, and where that's going to come in, I would have it then changing names into my brachial artery. So let me see, let me raise this up. Alright, so if I made brachial, okay. So axillary artery, after it passes underneath first rib is going to be axillary artery as it passes underneath teres major, becomes brachial artery. It's all the same continuation. Okay? And brachial artery we won't really even talk about until we get into the arm and then the forearm. Okay, and then it will, you can see it's going to split. Again, kind of like we had posterior tib and fibular artery, except here we have radius and ulna. Okay, no fibula in the forearm. Okay, so we also have coming over, we have this thoracoacromial branch, which is here, and that comes across to the supply structures in and around the acromial process. All right, we have my vertebral artery is sort of on here. Okay, my vertebral artery is going to start right here. Okay, but that's all, you know, we did this section right here when we talked about head and neck. Okay, so today we're trying to focus on arm. My circumflex anterior and posterior. Those guys should be pretty easy to identify. They're going to come around the head of that humerus just like we had at the actual femur. Now, we don't have the same issues that we had in the femur in terms of blood supply that we have in the humerus. Okay? The femur was oriented a lot deeper in that acetabulum, and we had that ligament to the head of the femur that was helping with a little bit of static stability in there as well. And we had the artery to the head of the femur. Okay? We have our circumflex here, yes, these can get compromised, and then we make sure that we are taking a really good look at the head of the humerus. But there's so many muscles that are attaching to the actual head, the rotator cuff is there, that we have a lot of blood supply that actually supplies the head of the femur. So we don't have the same issues that we have with the hip, right? Because a lot of the muscles for the hip attached at the trochanters, right? Those weren't up on the head, okay? So we don't have the same issue where, like, if blood supply dies to the head of the humerus, we don't often have, like, avascular necrosis of the arm. What we do have, though, is if we compromise, like, the growth plate or the circulation of the growth plate, somebody could have a shorter arm, okay? But then they just could rot because you don't want to have one arm longer than the other one, okay? But it's not as big of a deal because we have a lot more dynamic structures here, and those dynamic structures have their own blood supply, so that then supplies the head of the humerus. Okay, so what are we missing? We're missing a little one that goes and wings around the back. Circumflex scapular. You'll see this when we get to the back. Where is circumflex scapular? Is here, so that's this guy that takes a right-hand turn right there. Okay, thoracodorsal. Running out of colors. Let's do this one. Thoracodorsal is going to be this branch right here, and you should start thinking in your mind, oh yeah, that would kind of be where the lat would be if it was pictured in here, and the thoracodorsal nerve is what supplies the lat. So that's what I give it that same name. Okay, so I did not do internal thoracic. Internal thoracic is internal. So your internal thoracic, okay, is right here. Okay, so the dotted line means it goes behind the clavicle, creeps in front of that first and second rib. Okay, subscapular. I did not identify your subscapular. Okay, subscapular is dealer's choice. There are some people that will call the subscapular artery a tiny little portion of the transition between your axillary artery and your brachial artery. Okay, so I put it in there. So if we go back one slide, okay, so here it says I get my axillary artery down to the inferior border of teres major, and then it continues as a very short portion is the subscapular artery. The subscapular artery, they say, has these two branches that come off of it. So that's why some people identify it as the subscapular artery, because there's two branches that happen right at that point where that name transition happens. So I don't spend a lot of time really focusing on the subscapular artery because I think it's like an anatomical sort of debate that they have, but I put it on here because you'll see it in the book. I really am focused on subclavian, axillary to brachial. Like, you will see this in your book, and that sentence that I took out about it runs in a very short span, that's directly from the book, so I didn't want to have anybody be confused. Okay? Alright, so here's just everything identified for you. So this is where I highlight for you. Alright, pinch and zoom. Are you going to work for me? No. Alright, let's see. Can I do this? No. I can just move it. Alright, so let's try to do this another way. On this diagram, I'm smarter than I think sometimes. On this diagram, which is different than the one we just looked at, they have a tiny little branch coming off right there. That's what they identify as their subscapular artery. So that's why I say there's an anatomic debate. So some people say this section right here is your subscapular artery. And some people say there's a little branch that comes off of your axillary artery that's subscapular. I don't care. Okay? I don't care about the debate. Alright, so I just want you to know that whether or not you have this little alternative branch, or it comes, if you don't have that branch and it just, you know, stays widely patent right here, you're going to get your circumflex scapular arteries coming off as a branch from that portion that they refer to as the subscapular artery. But of all the things that I'm going to ask you, that ain't going to be one of them. Right? I mean, you guys know what kind of questions I ask about blood supply. I'm like, you cut your brachial artery, what is going to be at risk for not working? Or I'll say, you have a fracture in your humerus and it's near the head of the humerus. Which part of the blood supply do you think is going to be compromised? Okay, or your patient has a blood clot in their anterior circumflex humeral artery. What does that mean to you? Okay, so I'm not really going to ask you about the branching. You have a patient who's going to have their first rib resected. Which artery is going to be at risk for being compromised? Okay, so. But I like to alert you to anatomical debates, hot topics. I don't want you to feel left out at all. Alright, so looking at the back of the shoulder, this is a lot less complicated because a lot of it was from the front, and it just winds around to the back. Okay? So we have an artery called the suprascapular artery. Should make sense what that is going to supply, just like our suprascapular nerve that we have. Okay. We then have a dorsal scapular artery. Okay, so that's going to come around, supply here. We have our circumflex scapular that we looked at from the front, but we said we couldn't really see it all that well. And then we have our friend, the big axillary artery that we can see right here. Okay. And then interestingly, what we have happening is we get underneath that teres major, and then we become our brachial artery. But what we get is we get intercostal arteries that are coming from in and around the rib cage. Okay, and what they will do is they will anastomose, so they will form junctions with branches off the circumflex scapular. Okay, so they will join together in harmony and supply basically infraspinatus, teres major, teres minor, some of the rhomboids. Okay, anything that attaches to the medial border of the scapula or the infraspinous fossa. Okay, so a lot less complex on the back. So veins, you all know how I feel about veins. All the things you need to know. Veins aren't one of the biggies, but It's in the opposite direction of the arteries. So these we talk about not supplying, we talk about them draining. All right, and because we have just a lot of patients that have surgery in their axillary area, all right, I think it's important to actually mention a few of the veins. Okay, so a couple of the veins that we have brachial veins. Okay, and we have the basilic vein. Yes, we moved, Tom. I know you're confused. And the brachial veins and basilic veins, right, because the veins are going up, they are going to merge. All right, so those are two pretty big venous systems, basilic and brachial. They are going to merge at the teres major. Okay, remember that was a critical muscle that we looked at of where we changed names from axillary artery to brachial artery. So something's going to happen in the venous system. Basilic and brachial veins come together, and what they become at that teres major is the axillary vein. And then, lo and behold, it goes up to the first rib, and it becomes the subclavian vein. So it mimics what happens in the arterial system. All right, but you will see these very large veins when you do your brachial plexus dissection. Okay, and most of the time, what you guys think is that they're in the way for you to actually see the nerves, which they are. All right, but you can have a lot of, there's a lymphatic system that is weaving all through here. So when you guys, I don't know if you remember, but the very first tutorial case that you did was the lymphedema case in the upper extremity for the patient that had lymph node removal secondary to breast cancer. So this is an area of importance that we will note with our patients, and they may also have like bulging veins just because of the surgery that they may have had in that area. So this is a plastinated cadaver, so you can see how the venous system comes in, and you're just at a real increased risk of nicking something and causing a lot of internal bleeding. So it's a lot better to have a vein be compromised during a surgery than it is to have an artery be compromised during a surgery. But still, you can get a ton of blood loss because look at how large these are. Okay. So the other thing is when they do these surgeries, or they do like a resection of the first rib, or even of your clavicle, they have to make sure the end of it is completely smooth and there's no hardware that can snag any one of these vessels. Okay. All right, in terms of deep veins of the shoulder, all right, so again, only some of these are bolded, so those are the only ones I really care about. So we have that axillary vein. Okay, so remember that was the convergence of the changing of the name into the basilic and the brachial came together into the axillary vein, and then the axillary vein will change names into the subclavian at the first rib. Okay. Vena cava is kind of important. Talked about that, how it will resupply blood into the right atrium, and then our brachial veins. Okay, brachial veins, they're very superficial, so you can see those. So people, oftentimes will be asking you like, "Oh, I have this like varicosity," and what is that? So just for you to know that they're very superficial, you can see them. The only place we'll really talk about veins in the upper extremity to any degree more than this when we get to the cubital fossa, okay, because your veins are very superficial in your elbow, okay. And we have a lot of people, that's the place where they do blood draws most frequently, so knowing if they, because you'll have patients that will come in and see you after they've had blood work, so if they missed getting into an artery or a vein, then they can have a lot of edema, discoloration, and bruising, and just for you to know the anatomy of where they are, and just so that you can reassure the patient and have them not freak out over it. All right. Reminder. Ding, ding, ding. Here's your brachial plexus. Okay. So my lateral cord was C5 and C6, like you guys all told me. My posterior cord was C5 through T1, and my medial cord was C8 and T1, just like you guys all told me a few slides ago. You knew that. Okay. So you should be at the stages tomorrow and over the weekend of picking your favorite brachial plexus diagram and going to sleep with it on your chest bed at night. We'll be doing this again on Friday, starting to identify. All right. So just another note, love note. I really want somebody working on the neck while somebody else is working on the arm and brachial plexus, because I want to be able to see, here's scalenes. So I don't think anybody has their scalenes yet, but you can see the roots coming out through the sides of the scalenes and how they could get compromised. So my dermatomes. All right, so why do we even care about the brachial plexus? This guy's going to tell us all of this stuff about all the peripheral nerves, and we're going to have to do that loud. Great. Okay, so looking at the hand, arm, and shoulder. Okay, so we did the neck, and I said C3 is going to end right sort of at the superior clavicle. C4 is the top of your shoulder, so like your acromion. Okay. Then I have C5 is on my thumb side. So is my thumb lateral or medial? Lateral. Okay. So my thumb side, about to my cubital fossa. All right, is C5. And then we're going to learn autogenous zones. Okay, later. Autogenous zones in the hand are pretty easy because you just go on either side. And then you have fingers that are autogenous zones. C6 is going to go just from inferior of that lateral cubital fossa and incorporate my thumb and part of my index finger. C7 is going to be the tall man, okay, the middle finger, and part of my ring finger, sometimes part of my index. C8 is going to be my pinky, okay, and that's going to come up the medial side of my forearm up until my cubital fossa, and then T1 is going to be medial cubital fossa almost all the way to my axilla. Okay? So we will get familiar with those. And then the back of my hand, that's where, so C7 is kind of the sliver that goes from my middle finger. It's on the palmar surface of my hand, but you can get a little bit more C7 on the back of the hand as well. Okay? Interestingly to note is this division line right here. We will also be using this division line, which is midway down the ring finger, the fourth digit. Is also going to be the division between the median nerve and the ulnar nerve. Only on the palm. Radial nerve is the whole back of the hand. Right, so on the palm, we have a choice of median or ulnar. So median is going to be thumb, index, ring finger, middle finger, and half of the ring. Okay, but we'll go over that in great detail. But it kind of matches with the C7, C8 division. All right, so this is just a description of where you can find these things. Okay, cutaneous nerves. So again, on purpose, cut the arm off halfway because I don't want to get into the forearm. So these would be in your book. It's probably in like the first pages of your upper extremity lectures, but it would go all the way down to the hand because they're cutaneous pictures. Incorporate the whole upper extremity. All right, so my supraclavicular, because I'm hamstrung to the choices of colors that they use on here, is the rosy pink color. Okay, that's my supraclavicular cutaneous distribution. Anybody remember where supraclavicular came off of? Cervical plexus. All right, so it doesn't have a parent nerve. Okay, so it has no motor. All right, so it's just its own cutaneous nerve. You'll look through it again. I know. It'll come back from the dead. Maybe we should start with neck tomorrow. It's your activity. All right. Then we have the superior lateral cutaneous, and that comes off of your axillary artery. I just said artery. Somebody correct me. Axillary nerve. Okay, and that's this sort of violet area. So axillary nerve supplies deltoid teres minor. Okay, so if you had somebody with axillary nerve damage, they would have a lot of shoulder dysfunction, and then they would have decreased sensation on their lateral shoulder up near the acromion process. Okay, we then have a intercostal brachial, which is this light green color. I'll get to inferior lateral cutaneous in a second. So this is your intercostal brachial, and that comes from the second intercostal motor nerve. And I know I'm skipping around on purpose. Then I have the medial cutaneous, which is yellow, okay, which is also its own cutaneous branch. Look at this. No parent nerve, medial cutaneous nerve VR. CAT1. Okay? So I don't even have to put that on there. There's also a medial cutaneous nerve in the forearm, also CAT1. Okay? Which, Steve Dermachol! Thank you, Todd. Okay? And T1 is here, right? We just said CAT1. Okay? Ooh, that's matching. I like that. Okay? But no parent nerve comes right off the brachial plexus. So this would be akin to lateral cutaneous nerve of the thigh. L2, L3. Came right off of the lumbosacral plexus. Okay? Alright, so why I skipped, and this is the one thing I hate about CLA, is I skipped inferior lateral cutaneous and posterior cutaneous, okay? So the book likes to do, we talked about this before, the color coding according to parent nerve, which that part I like, okay? But what it does is these both come off the radial nerve. So radial nerve is what it's coloring on here. So radial nerve is white. So it's like, oh, they both supply white, okay? Or their parent nerve is white because they're both radial nerve, but they don't really tell you what part of the arm they're actually supplying. So I'm going to kind of try to supersede them a little bit. So the inferior lateral cutaneous, okay, is this nerve right here. Okay? So it's going to do approximately that area. And then the posterior cutaneous, obviously, we cannot really see that this well on the anterior side. It's over here. Okay? And it does that little part right there. So what the book does is it labels the yellow nerves, and it will have like leaders going to that nerve, and it would call it, that would say like, oh, this nerve right here, that's my inferior lateral cutaneous. This one down here is my posterior cutaneous. But it colors them in both white, they both come off the radial nerve. Okay, so here you would see it on the posterior side. All right, so my supraclavicular, the color's the same. My superior lateral cutaneous, the color's the same. Intercostal brachial, same color, it's just like green. That does all right here. Okay, and then here's my medial cutaneous. Okay? We are ignoring this part right here. I don't want to do it right now because it's called the ulnar branch. We don't care about that right now. All right, so I purposely did not label that for you guys. Okay? So don't worry about it right now. All right, so those are your cutaneous nerves. Here's a little table that you can find in your book, right, that would tell you contributing nerves, and then you would see things like, oh, cervical plexus, medial cord, right, so it just comes directly off the radial plexus. Or it would say the parent nerve, radial nerve, okay, or axillary nerve. So just getting you back into the habit of looking at those things. All right, so I don't want to, what's the slide after this? All right, I'm just going to do these two more because I don't want to make you guys late for your next class. All right, so we're going to talk about injuries. So we will spend a lot of time next Monday talking about injuries to the brachial plexus, okay? So, again, I was saying they can happen anywhere from right at the root all the way down to the hand, and then the symptoms and signs that will result you can sort of trace back and say, oh, this is probably the injury. Or you do the opposite. They can tell you the mechanism of injury, and you're like, oh, it makes sense if you would have these signs and symptoms, and they all line up. Okay? So if you were to have a superior brachial plexus injury, now we're talking about superior trunk. Okay? Really up high. So we have roots, and we have trunk. Right? Superior, middle, inferior trunk. Superior trunk is C5, C6. Remember that? They go together. Middle trunk is just C7, it's a loner. Inferior trunk is C8, So if you have a superior trunk injury, you're going to have symptoms that look like C5 and C6. Right? Things that you could have that would lead to that would be trauma. You could have an infection, a wound, right? So either like a stab wound or a surgical wound. Okay. Couple of different things that result from this, right? You can have a condition that's called Duchenne palsy. That happens it can happen when a baby is being removed during delivery, and there's so much traction on the neck that it actually leads to a C5, C6 traction injury. Okay, most of the time they will resolve, okay, but not always. Head sometimes down, rip, C5 and C6. Okay. So, just to itself. So then what happens is, if you have no C5 and C6, real loss of shoulder function and elbow flexion. All right, like I said, a lot of times it comes back, but not always. Okay. This description we have of this gentleman down here, we call this the waiter's tip, right? Which is if a waiter, is being kind of shady, they want to tip, they'll go like this. It's not being fired. Okay. So with a waiter's tip, this is the resting position of the arm, which you can't. We've lost axillary nerve. Okay, so you're like this. So if you have really bad Duchenne, well, your left is in a waiter's tip. This is also one of the maneuvers they teach you in the CIA. Go here, go here. You're trying to render the brachial plexus ineffective, so that totally paralyzes the arm temporarily. Or I suppose you're in the CIA and you do it permanently as well. But it's to get the person in this position, because then they can't wield the weapon if they can't move their arm. So I told you they were all in the anatomy lab. Secret service. Not so secret. And they were looking at the brachial plexus specifically, and they were looking at how it goes through and where they could potentially cause an injury to an unsavory character. Don't fall like this. I have another awesome slide of a guy hanging from a tree, and a cannonball hits him in the armpit. Don't do that either. It's very bad for you. But, I mean, with all these Spartan races, you're climbing over walls and it's muddy and you're an idiot. Right? So that is the same issue, right? So the head and neck is going one way and the weight of the body, or, skiing, like that's going to happen too, or snowboarding. Head and neck goes one way, body goes the other way, right? So worst thing is you get a spinal cord injury if you fracture your spine. But you can get traction injury on that superior cord. All right, so we will talk a lot about what C5 and C6 does, but you really, when you lose C5 and C6, you'll lose musculocutaneous, part of your median nerve, and you'll lose, a lot of the contributions that go to the, would have gone to the posterior cord, so you'll lose axillary. All right, so here you can also have inferior, so if you have a baby and they pull it by the arm, instead of by the head, that's bad too. So that tractions your inferior cord. So that's C8T1. So this would be my guy. I used to have a slide, cannonball hitting him under there. But again, really tractioning and getting that inferior cord. What you will actually get, one of the things is called clump feet paralysis. But C8T1 is ulnar nerve. All right. So if you had to choose, I'd rather get a C8T1 than I would get a C5, C6. But what happens is you get clawing of your hands, because we'll talk about much later that if you have unopposed pull of your hand intrinsics, because the ulnar nerve supplies a lot of your hand intrinsics, just like what we talked about in the foot, okay, with the medial lateral plantar nerve, So, like, think of ulnar nerve like your medial palmar nerve, but it's ulnar. And then you have median, which stands for lateral. So if I have an intact median, but my ulnar is not working, I can't flex my pinky. So if I go to make a fist, it might be like this. Right? So, you know, not having use of your ring finger and your pinky is a lot easier to deal with than not having shoulder function. But you get a static deformity, like your hand will look very odd, right? So you just want to be mindful of things that will happen down there. All right, so that's just a little intro to what happens if you get a really high injury. Then you lose everything down the line. So if you injure C8, C1, anything that has C8, C1 would be weak. So your posterior cord will still be okay because C5, C6, C7 are still there. Median nerve is still fine. Musculocutaneous is still fine. But ulnar is only C8, C1. So you would lose a lot of ulnar nerve stuff. Okay? So I will see you guys tomorrow. Again, I'll be a little tardy. Don't be